Good morning, everyone. My name is Nina Murray, and I'm Head of Policy and Research at the European Network on Statelessness. It's a real pleasure to welcome you all today on behalf of ENS to our webinar, which is entitled Statelessness and the Right to Health Beyond the Pandemic. For those of you not familiar with ENS, we are a civil society alliance of over 160 organisations and individual experts working to address statelessness in 41 European countries through law and policy development, awareness raising and capacity building. We're very excited to have had over 220 registrations for the webinar today. Please do say hi in the chat, and if you like, tell us your name and your organisation, where you're joining us from today. We're also going to be posting a quick poll just now to find out a bit more about our audience. I'll ask my colleague to post the poll for us. That should come up on your screen. I can already see that there are over 80 people with us right now, and the number is rising, joining us from different countries and regions and a range of different backgrounds, including NGOs, stateless activists and community representatives. We have some European institutions joining us today, UN agencies, civil society, and more. So I'm just looking at our poll here, asking whether you work or advocate on the issues that we're going to be talking about today on statelessness and the right to health. So I'll give you a couple more seconds to answer the poll. So we're interested in whether you're working on the right to health of stateless people, whether you're working on statelessness specifically or on health rights specifically, or none of the above. So please do answer our poll. So today, excuse me, we're launching our new report on statelessness and the right to health in the COVID-19 context. And my colleagues will share the link to the report, which has gone live this morning in the chat box. And as the Council of Europe Commissioner for Human Rights, Dunja Mijatovic, said in the foreword to our report, more than a health crisis, the COVID-19 pandemic has developed into a rights crisis affecting us all, but it doesn't affect all of us equally. And our research report and policy briefing sets out why regional and international institutions, states, public health officials, service providers, and all of us here today need to act now to address the challenges that stateless people are facing as a consequence of the global pandemic. So thank you very much for joining us. Thank you for filling out our poll. I see that we have a number of people, around 25% of you working on statelessness and the right to health, which is fantastic. Others of you working on statelessness, but not necessarily health rights, and some of you working on health rights, but not necessarily statelessness. So thank you for that, and it's always great to hear who's joining us today. So I can see now that we have over 100 participants, which is great. So do keep saying hi in the chat. I'm seeing people from Ukraine, Denmark, and all the way from Bangladesh. So welcome to all of you. And thank you for taking the time out of your busy days to hear more about these issues and what we need to mitigate them. As I said, you can now access the report and policy briefing that we're launching on our website and soon in the chat as well. Before I tell you a bit more about the programme for today and who you're going to be hearing from and our exciting lineup of speakers, just some quick housekeeping, although by now I'm sure you're all very familiar with Zoom and its functionalities. But just to let you know that we're recording the session today and we will make it available publicly afterwards, so you can share it with your friends and colleagues. The chat is not visible in the recording, so just so you're aware. Participant microphones and cameras are switched off, you will have already noticed, but we really encourage you to ask questions and comment in the chat box as we go along using the all panelists and attendees function. And of course, feel free to email us afterwards with further questions, comments, or feedback. So the aim of today's webinar, as I said, is to present the key findings of our research on statelessness and the right to health and our recommendations for action in 8 key areas in which statelessness is intersecting with other risk factors and vulnerabilities to undermine the right to health for stateless people in Europe and beyond. So after a presentation of the main findings of the research report by our lead author and researcher, Professor Marie-Claire van Hout, I'll briefly present the key recommendations. We then have a fantastic lineup of speakers. So we have 5 experts who are going to offer their reflections on the report and give us their recommendations for the way forward from the perspective of affected communities, international and regional organizations, and civil society. We're going to hear examples of how stateless communities have been affected by the pandemic, as well as insights into how civil society and others have been responding to the challenges facing marginalized and minoritized communities at this time. We hope that there will be some time for questions and discussion at the end, so please do get your questions ready, post them in the chat as we go along, and I'll try to put as many of them as possible to our speakers at the end. So without any further ado, let me introduce our first speaker, who is Professor Marie-Claire van Hout, who, as I said, led the research for us and is going to present the key findings to you. So if I can ask Marie-Claire to switch on her camera. Marie-Claire is Professor of Public Health Policy and Practice at the Public Health Institute at Liverpool John Moores University in the UK. She has over 20 years experience of evidence-based research in public health, human rights, health disparities, and health risk behaviours in Europe, in the Middle East, and in North and Southern Africa. And Marie-Claire led the research for ENS along with her colleague Charlotte Bigland, and is now going to give you an overview of the research findings. Marie-Claire, are you there?
Yeah, I've turned on my my video. I don't know if you can see me, and I'm sure you can hear me okay?
I can see you now. Go ahead, Marie-Claire, over to you.
All right. Thank you, Nina. Thank you, everyone, for attending this exciting webinar. I'm really delighted to present to you the key findings from this research project undertaken for the ENS. Next slide. Okay, so the first and foremost, just to give the funding statement. So the research was commissioned by the ENS and funded by Rosa Luxemburg. And in terms of the aims and objectives, so we conducted a rapid situation assessment to better understand and explore the nexus between statelessness and health before COVID-19, but also during the COVID-19 pandemic times. The key objectives were really to understand the link between being statelessness and health outcomes and health disparities. We intended to use the report to make a series of evidence-based policy recommendations which ENS can now take forward. Nina will be presenting these recommendations to you when I finish up. So essentially, we looked at the barriers to accessing healthcare in general, and also how these were experienced during COVID-19. We wanted to look at the impact on health outcomes and health experience. And we wanted to have a look to see what the commonalities were across European countries and in the region itself. And also identify some areas for future research and future advocacy. Ethical approval was granted by our university, Liverpool John Moores University. And as Nina explained, I'm presenting on behalf of myself and my researcher, Charlotte Bigland. Next slide. So there were 3 phases in the research. The first one was an online survey which was administered by ENS to all its membership list, and these were the key stakeholders in all Council of Europe member states. 29 key stakeholders completed this survey, and you will see there that the inputs that they provided represent 20 Council of Europe countries. Phase 2 was a series of interviews and small focus group discussions using MS Teams with an agreed listing of key national and regional expert stakeholders in Europe. So 19 in-depth interviews were conducted, representing the region itself in terms of those stakeholders who had a remit for the region, and also specific country level perspectives from Germany, Ukraine, Netherlands, Greece, Spain, United Kingdom, and Italy. And phase 3 was a peer-led participatory research element, which was actually led by community NGOs. And this is where they conducted focus groups with individuals who were stateless and stateless communities themselves. And this yielded 5 in-depth country case studies. So all in all, the 3 phases were combined, and they were analyzed using a triangulation approach to look to see what were the common themes arising from these 3 different types of data. And again, as I said already, they were then combined and analyzed, and ultimately have generated a series of recommendations. Next slide. So first and foremost, just to say that there were some challenges encountered in this research, and they were rather unexpected to us as researchers. There was a lot of uncertainty from respondents with regard to their answers, particular to statelessness. So many felt that they didn't have the specific knowledge and insight to really refine their answers to refer only to stateless persons. It became very apparent that stateless people are hidden within groups that are, disproportionately affected by statelessness. Key examples would be migrant communities, Roma communities, and ethnic Russians living in the Ukraine. So whilst it was challenging, it's still indicative of a lack of specific data on stateless people. It highlights that they are still hidden, and it is still an invisible issue. On a positive note, across the 3 phases of data that we collected, there was very strong consensus around the findings regarding health and statelessness before and after COVID-19, with no outliers observed. Next slide. So first and foremost, to say that, with regard to the right to healthcare being a fundamental human right, and, underpinned by non-discrimination, this appears not to be the case for stateless people in Europe. There are marked and significant differences in healthcare provision accessibility by stateless people in different countries and before and during COVID-19. So this centers on the requirement of individuals to have legal documentation, formal identification, or health insurance. And for many stateless individuals, they don't have this, and this hinders their access to the mainstream medical care. For example, in many countries, migrants are only able to access emergency medical care. This became very apparent as a barrier during COVID, and it actually resulted also in very poor health outcomes. The financial costs towards accessing medical care represent a huge barrier, especially for those who don't have the ability to self-fund or don't hold medical insurance. One thing to note is that mental health care came up through and through in the report, that stateless people, they are disproportionately affected by poor mental health. And as a result of not being able to access mainstream medical care and the continuity of medical care, and this means access to dedicated mental health supports, they were really severely affected by this. And one quote was very interesting: "Invisible people, invisible virus." And this is something that I'm going to talk about in the next few slides. Some specifically vulnerable stateless individuals are those who are elderly, those who live or work in confined spaces, those with existing poor mental health or other identified COVID-19 risk factors or comorbidities, and also women who are affected by domestic abuse. Next slide. So one thing that came through in the report is that the cessation of general health services during COVID-19 outbreaks and surges impacted on the health of all, but in particular stateless individuals, especially those who needed specific specialist mental health and medical care. The reconfiguration of health services during COVID-19 also impacted on the ability of stateless individuals and also the groups to which they belong, which are disproportionately affected by statelessness, their ability to engage with medical care professionals during COVID-19. And what I mean by this is that many countries shifted to digital operationalization, and this disadvantaged those without access to the internet, without access to laptops, and those who were confined to where they lived. And this was especially the case for stateless individuals. The requirements for having an ID or formal documentation differed with regard to COVID-19 testing. There were some anecdotal reports of individuals being turned away from hospitals despite having COVID-19 symptoms because of a lack of documentation. And there were also some reports of those with severe COVID-19 disease leading to fatalities as a result of an inability to access medical care. Next slide. So what's important to mention is that COVID-19 has amplified institutional mistrust. And this exposes stateless individuals and the groups to which they belong to increased health risks and poorer health outcomes. There was an observed rise in political rhetoric and hate speech, blaming, for example, the Roma communities and migrant communities for the spread of disease. There's also a very important finding here that there was an observed heightened fear among stateless people and their communities of contracting COVID-19 when accessing health services. There were fears around the refusal of medical care, and there was a very strong fear that their information would somehow be shared between the medical practice or the hospital and the immigration authorities. Excuse me. And this has led to a reluctance to engage with medical and healthcare services. Encouragingly, there were a few attempts made in Europe by government to create a firewall between health and immigration, for example, in Ireland. Civil registration procedures such as birth and death registrations continued to take place. However, there were many instances where procedures requesting acquisition of nationality stopped or were intermittent, and this left many individuals in limbo with regard to their nationality status. And of course, this impacted on their ability to access social and health services. There were observed delays in statelessness determination, residence permits, and asylum procedures during COVID-19. And also the actual physical restriction measures impacted on access to lawyers and legal representation. As I mentioned already, there were government shifts towards digitalization, and this meant online renewals of residence permits in some countries. And again, those who didn't have access to internet, laptops, etc., were disadvantaged and weren't able. There were some positive notes. Some governments automatically extended their temporary residence permits, and others, for example, Switzerland, failed to provide any amnesty to those with an expiring temporary residence permit. Most concerning were some reports of releases from immigration detention without follow-up social assistance or housing assistance, and this leaving people homeless, and again at severe risk of COVID acquisition. Next slide. With regard to the environmental determinants of health, in terms of stateless communities or the groups to which they belong, to say that conditions of housing obviously have an impact on ability to adhere to the public health guidance regarding social distancing, levels of hygiene and sanitation, and mask wearing. And this was extremely difficult for Roma, for example, and also for migrants. There were also some reports in a reduction of medical care for those living in refugee camps and in immigration detention. And again, the financial means to implement public health guidance was not possible for some. Next slide. I'll finish up soon. In terms of the data, there was a lack of comprehensive data on statelessness itself, and they were generally not included in public health measures. The NGOs backfilled this requirement by providing the information in language, by accessing communities where they were living, using mobile health units and other remote technologies themselves. Next slide. And lastly, to build on this is that the NGOs actually really took step here, and they were the ones that had the trust with their cohorts that they engaged with, and in this way they were able to disseminate COVID-19 information. And this is actually most important now when we think about vaccination programs and the practicalities of rolling out vaccination, making sure that stateless individuals are included in the rollout. And also for those who are homeless or living in different areas, NGOs are absolutely crucial to support health services in administering, especially the 2-dose vaccination programs. There are some very positive best practices. In some countries, there's free COVID-19 testing, free COVID-19 vaccinations, and also the Patients Not Passports toolkit in the UK is most encouraging if it's implemented correctly. Last point to note is that in terms of the NGOs, they're also crucial in overcoming institutional mistrust. The very fact that stateless individuals and their groups are afraid of authorities could potentially hamper a sufficient and comprehensive COVID-19 testing and vaccination rollout. Thank you. Over to Nina.
Thank you so much, Marie-Claire. Thank you very much. And there's so much to present. I know we could have spent much longer, but thank you for giving us that overview of the key findings. And I want to now very briefly present our key recommendations, which focus on guaranteeing the right to health for stateless people, improving the public health response to COVID-19 for stateless communities, and also leveraging the COVID-19 pandemic to secure policy reform towards ending statelessness and the discrimination and rights violations that stateless people experience. So we make a number of recommendations based on the findings that Marie-Claire has outlined and which are summarised in our policy briefing, which we're also launching today alongside the report. And we call for targeted interventions to ensure equal access to healthcare for stateless people, regardless of their legal status. For example, we recommend, as Marie-Claire said, free universal access to COVID-related care, testing, treatment, and vaccinations. We also recommend the adoption of firewalls between health and immigration services to help reassure individuals who lack legal status that it's safe for them to access health services. We call for explicit inclusion of stateless people in vaccination programs and careful consideration, as Marie-Claire said, about how to reach marginalised communities excluded from healthcare systems and how to secure their consent and ensure follow-up in communities where lack of institutional trust is going to hamper government efforts to to roll out vaccination programs, and we recommend the authorities work closely with trusted NGOs and community organisations to achieve this. We call for more to be done to ensure stateless people and representatives of communities affected by statelessness participate in public health planning and decision making, so that health information and public health campaigns are accessible and relevant. Stateless people also must have access to essential social security and state aid packages, which should be available to all based on need, regardless of legal status. We call for norms of due process to be upheld in legal procedures, for civil registration to be designated as essential to guard against new risks of statelessness emerging during a pandemic, and for progressive policies that put people and the right to life, the right to health first during a pandemic. And we recommend that all those who lack legal status should have their status regularized during a health emergency to ensure they can access essential services. Of course, as we all know, the backdrop to the pandemic has been a worrying increase in xenophobia, racism, and anti-Gypsyism. And while not necessarily specific to stateless people, the effects of this have been borne by migrants, refugees, Roma, people of colour, and minoritized groups. So we call for more to be done to address these trends, both publicly and institutionally, to eradicate politically charged xenophobia and racism and concretely address these issues. So our overall message is that it's not too late to take action as vaccination programs are being rolled out and the world looks ahead not just to the fallout of COVID-19, but to the prevention and mitigation of future pandemics, that now is the time for these measures to ensure the inclusion of stateless people in public health planning and responses. So we urge policymakers to think about progressive policies, to take concrete action, to identify who it is that we're leaving behind now and how to ensure that they catch up. So with that, I want to turn to our panel of invited experts to now hear their reflections, responses, and recommendations for the way forward. So each of our panelists is going to give us their 5-minute reflections on the report and our recommendations from their different perspectives. And first of all, it's a real pleasure to introduce Elvis Perisher. So Elvis, if you can switch your camera on. Elvis is Executive Director of the Roma youth organization Walk With Us Firanamenta in Montenegro, and has a wealth of experience working in the communities in Montenegro and beyond to address some of these issues. And Elvis is going to speak for 5 minutes from his perspective. So over to you, Elvis.
Thank you, Nina. I hope you can hear me and see me.
Yes, we can. Go ahead.
Thank you. So I want to thank you for inviting me on this really important event, and also to say hi to all our participants and my colleagues, panelists. It's really an honor to speak in front of you and alongside of you on behalf of the Montenegrin and worldwide stateless Roma community. I don't stand before you as a stateless person, but I easily could have been. I stand before you as a spokesperson who for those who cannot do it for themselves. So for 17-year-old Comriam, who lost her documentation in a fire that occurred in the largest European Roma camp, Konik, in capital city of Montenegro. For Gzim Mustafovic's kids, 6 of them, all without documentation, even though Gzim is Montenegrin citizen. For 35-year-old Agron, who waits for the Montenegrin government to extend his documents. He has been waiting for 3 years now. And for Vidaim and his 2 kids with cerebral palsy. All of them are my neighbors and they live 5 minutes away. The story of statelessness is that it exists somewhere else, far away. But this is not the reality for Roma communities around the world. Members of this community without regulated legal status live like shadows, barely surviving, most likely within easy reach of city landfills. Persons without legal status aren't only missing documentation, they are missing out on a dignified life, on education, on a normal job, roof over their heads, healthcare, and in the time of a pandemic, they are missing out on relief packets that come from the state's hands. Out of four state aid packets that have been provided in Montenegro, the Roma community with unregulated legal status have received nothing. Twice 50 euro, then 200 and last 100 euro of state aid would certainly make a difference for the families living from collecting secondary raw materials. Roma Youth Organization worked with us Pirenamenza with the support of ISI, recently did a mapping or mapping of statelessness in Podgorica, and the research revealed 198 adults and 216 children with unregulated legal status at risk of statelessness. According to official data of the Montenegrin Ministry of Internal Affairs and many other national reports, that number is close to zero. Our research has showed us that in future, this number will multiply because already the number of kids with unsolved legal status is bigger than the number of adults. These people are trying to preserve their health, but without health care. Every doctor's appointment needs to be paid for every medicine as well. I mentioned Bedaim and his kids. On a monthly basis, he needs 60 euro for worth of the most common medicines. And he tries to make that much money by repairing old vehicles. When new date, Dule Hairize was waiting for his wife and child to come out of the hospital, he asked our organization for help because he didn't have the money to pay their hospital expenses. We could not guarantee anything, but we advocate on their behalf to the clinical center to exempt them from payment. Fortunately, that is what happened. They came out of the hospital with congratulations, no bills in hand. This is one of the rare cases when communication was established with the Ministry of Health, who made such a request and explained that there is some fund for such cases. Yet childbirth is an emergency. What about other illnesses that this community suffers from and does not cure? Legal status, citizenship is not just a document. It's a permission to get a vaccine at the same time as everyone else, permission to learn in the same conditions as everyone else, to get a free meal a day, social insurance, a job, and etc. So Montenegro has made the pledges to European institutions and international organizations to do everything in their power to help reduce statelessness. Let's honor this by reopening a public call from 2015, so people can again apply to resolve their legal status. Let's simplify civil registration and citizenship procedures and truly give people the support they need during this pandemic. So on these goals, we have been working for over 3 years, but we need your help to put pressure on the Montenegrin government to make this a reality. recommendation from Mr. Fernand de Determinants and other join us today will take us a long way in the right direction. Thank you for your attention, and if you have any question, of course, I'm here. Thank you.
Thank you so much, Elvis. Thank you very much for sharing those really important reflections and recommendations, and really fantastic to have you with us today. So thank you. I'm going to move to our next speaker. We'll hopefully come back to you, Elvis, at the end for a final reflection. But I'm delighted now to introduce Mr. Fernand de Verden. Fernand was appointed the UN Special Rapporteur on Minority Issues back in August 2017. He also holds a number of professorships, including at the University of Pretoria, of Ireland and Galway, and University of Hong Kong. And his work focuses on the human rights of minorities, as well as on the prevention of ethnic conflicts, rights of migrants, and relationships between ethnicity, human rights, and democracies. And since taking on his mandate as a special rapporteur, Fernand has made statelessness a priority area of focus, and it's been an honor to work with you, Fernand, closely on these issues in the last few years. So over to you, please go ahead.
Thank you, Nina. Distinguished experts and participants, ladies and gentlemen, bonjour. I'm delighted to be with you, virtually, of course. But first, let me please allow me to thank and congratulate the European Network on Statelessness and the Public Health Institute at Liverpool John Moores University for this very timely launch of the situation assessment of statelessness, health, and COVID-19 in Europe, and for organizing today's webinar and policy briefing. It shouldn't need to be said, but the world is experiencing, as we all know, the likes of which, a pandemic, the likes of which we have not seen for almost a century. COVID-19, however, is not just a health issue. Social media has, for example, made it also a disease of the mind, propagating as a virus that exacerbates xenophobia, hate, and exclusion, especially overwhelmingly targeting minorities, and what the United Nations Secretary General Antonio Guterres termed a tsunami of hate and xenophobia. Now, this tsunami, unfortunately, has also amplified inequality, marginalization, and vulnerability. And the situation assessment, I think, demonstrates this superbly. And while there is now, well, it's now well understood, it still needs to be highlighted, addressed, and emphasized, as you have done by focusing on the stateless, because it is a threat not only to the most vulnerable and marginalized, but it is in the end also a threat to all of us. I think you've demonstrated once again superbly the obstacles, barriers, and in fact denial of what we should describe quite clearly, a denial of basic human rights, which the stateless are particularly being subjected to. Now, it's not possible for me to commend you enough on how you've lucidly and systematically identify the structural obstacles for many stateless. One point I think that needs to be also clarified is that since most of the world's stateless are also minorities, they often are amongst the poorest of the poor, the most vulnerable and marginalized. And as your assessment points out, all possible barriers are in fact, in a sense, stacked up in their case to deny them access to a legal status or formal documentation, as we've heard earlier, or even basic information to access healthcare. And ladies and gentlemen, please allow me to emphasize how central it is to emphasize here that many of those barriers, the barriers which your survey identifies clearly, could and should be deemed to be breaches of international human rights, particularly the prohibition of discrimination, which is one of the basic pillars of international law. Let me be clear. It's discriminatory to limit the right to health, to access to a vaccine, or to health information even, to combat the pandemic. And it is discriminatory to limit this, as we've heard already, to citizens, unfortunately. Perhaps what has been missing, but which I feel you have admirably tackled, by the way, in your assessment, is that pandemic responses and vaccination programs, for example, are not sufficiently focused on those who need it or need them most. These are minorities. These are the stateless. These are the refugees in camps around the world, including Bangladesh and in different parts of Europe. These are the minorities such as the Roma, which we just heard from Elvis, and Elvis, I heard your message. The minorities such as the Roma in many countries in Europe. These are the migrants that are huddled in sometimes, perhaps too often, poorly serviced neighborhoods. These are the poor who have limited access to health services, even to running water in some parts of Europe, let alone internet access, which continues, unfortunately, to exclude significant segments of the population. So let me just give you a quick example, which you have highlighted in your assessment, indicating that one significant barrier to COVID campaigns comprehension was language. And as the assessment clearly states, if public authorities do not reach minorities, migrants, refugees, and stateless in the language they understand, there's no communication. In fact, worse than that, you will have misinformation and disinformation. And the lack of, or rather the fear and lack of trust that we've also heard just a few moments ago in understanding will be more entrenched amongst or within groups such as the stateless and minorities. And this means that efforts to contain their virus, well, they're not likely to be very effective, obviously. And this may contribute to increased levels of ill health. So let me emphasize how obvious this should be, but that it's important to repeat and to highlight what needs to be done to effectively reach out and communicate with minorities and others such as the stateless. Until recently in countries such as Canada, where I'm now based because of COVID, as a matter of fact, it took a long time to effectively reach out in a non-discriminatory way to migrants and minority communities in their own language and in a culturally sensitive way to communicate and reach them effectively and increase the levels of vaccination and engagement with other pandemic measures. This should have happened a long time ago. It did not. For whatever reasons, there is the fallacy in a number of countries or within governments that information and pandemic information and health measures can be transmitted effectively by only using the official language. This is wrong. So to conclude, let me very quickly commend once again the European Network on Statelessness and the Public Health Institute for the concise and practical recommendations you've made on health information, digital inclusion, social economic exclusion, and the others. But let me end by just saying that this is not only a health issue. The main barrier almost always are breaches of the prohibition of discrimination or of non-discrimination, and minorities and stateless are increasingly being left behind. Thank you.
Thank you very much, Fernand. Thank you, as always, for your support and for your strong words of encouragement and important points that are being made about the way forward and some of the shifts that are needed in terms of the narrative and what needs to happen next. So thank you very much. Without further ado, I'm going to move on to our next speaker to introduce Mr. Dragoslav Stefanik, who Ambassador Dragoslav Stefanik, who took up his functions as the Special Representative on Migration and Refugees of the Council of Europe Secretary General in January 2020. Mr. Stefanik is a lawyer by training and a career diplomat. He was head of the Council of Europe office in Sarajevo, and prior to that, ambassador and permanent representative of the Slovak Republic to the Council of Europe, and has extensive experience in international diplomacy and human rights. So if I may ask you to switch on your camera, Dragoslav, and hand the floor to you for your 5-minute intervention.
Thank you, Nina. Thank you for giving me the floor, and I would like to thank European Network on Statelessness for inviting me to speak in this webinar. which is a very timely initiative, especially in connection with the access to health within the framework and the unfortunate context of pandemics. I would like to also thank our colleagues from Liverpool John Moores University for their research and for sharing us with the recommendation. I went through policy briefing and I really couldn't agree more with the number of things which you have highlighted and recommendations you have indicated. Especially for my interest, I was reading the part concerning barriers to access to healthcare for stateless people, and that report and those lines are really, I can confirm those with my own experience, where there are problems concerning lack of legal status, lack of identity documentation, in access to health insurance, institutional mistrust, sometimes discrimination on the part of the healthcare providers, and also quite often what I've also seen, and not only for stateless persons, that the migrants or refugees or asylum seekers are afraid to approach actually the healthcare services due to fear of their lack of legal status or the fears of the possible prosecution or even deportation as a kind of extreme measure. So I very much like your analysis, and also the barriers which are now connected with the COVID-19 pandemics, which are reduced appointments, digitalization of services, and quite often migrants, refugees, or asylum seekers that do not have access to, they don't have internet, do not have mobile phones at their disposal. So it's impossible for them to access these digital services, and then they stay out of the facility, the possibility to get the healthcare care. So in our system, in the Council of Europe, European Convention on Human Rights addresses more civil and political rights, and the counterpart kind of which is providing for the social, economic rights, including the right to health and access to health, is European Social Charter, which is the Council of Europe main binding reference, also concerning fundamental right to health. The Charter guarantees a broad range of everyday human rights related to employment, education, social protection, welfare, housing, and of course, health. It also refers to vulnerable persons. And as was also mentioned or indicated by previous speakers, especially by the UN Special Rapporteur on the minority issues, also the European Social Charter requires, in particular, that enjoyment of these rights, including the right to health and access to health services, shall be guaranteed without discrimination. So this is, I think, this should be underlying the principles when we are talking about the right to health, and that, of course, includes the stateless persons. Although I'm very happy we have this webinar and these activities, and once again I would like to praise ENS for their activities, because yes, as it has been also said by previous speakers, the stateless persons are quite visible category, quite often neglected or overlooked, but also by the states who are actually driving seats and which are negotiating the documents, recommendations, resolutions, etc. It's a good thing about the European Social Charter that it has the committee, it has the monitoring organ which is overseeing the implementation of the Charter, and that's European Committee of Social Rights. As regards the scope of the European Social Charter in terms of persons protected, it's also referring to refugees and also referring to stateless persons. And it says that each state party to the European Social Charter will grant to stateless persons, as defined in the Convention on the status of stateless persons from 1954, and lawfully staying in its territory, treatment as favorable as possible, and in any case not less favorable than under obligations accepted by the partner under said instrument. European Social Charter is taking into consideration the category of stateless persons. Of course, there is this limitation, which is not totally ideal, but of course it was a compromise by the states that it applies to those who are lawfully staying in the territory. Recently, speaking about the COVID-19 pandemics, we have moved a bit from the sanitary sanitation measures, isolation and testing to the vaccine. Now the agenda number one is vaccination and access to the vaccination without any discrimination, and access to vaccination also to migrants. And I was praising the government of Serbia, which was the first country actually which opened the vaccination also for a population of migrants in that territory. Recently, we issued with the number of other stakeholders, including the UN Committee on the Protection of the Rights of all Migrant Workers and members of their families, including the UN Special Rapporteur on the Human Rights of Migrants and the Office of the United Nations High Commissioner for Human Rights, Special Rapporteur on the Refugees from the African Commission on Human Rights, and also Rapporteur of Rights of Migrants of Inter-American Commission on Human Rights, including me. We signed the guidance note on equitable access to COVID-19 vaccines for all migrants. It's dated 8th of March. I think it's available also on the websites. And it concludes. It contains 6 key recommendations by which states are urged to provide equitable access to COVID-19 vaccinations. But I will not go into detail because we have limited time. By concluding, I'd like to say that the issue of stateless persons is not omitted, not by me, by my office, and by the Council of Europe. We are now in the final stages of negotiations on the new action plan of the Council of Europe of vulnerable persons in context of the migration and refugees agenda. And that action plan, of course, I can't jump into conclusions because it's still pending the agreement by 47 members of the Council of Europe. But it includes an actions which are pertaining and relevant for stateless persons. Once again, thank you to you, and I'm sorry if I overstepped my time.
Not at all. Thank you very much, Jaroslav, and thank you for those reflections. And also, it's great to hear that the action plan includes and encompasses some actions in relation to statelessness, which is great. So we look forward to seeing that when it's published. And thank you again. I'm going to move on, as I'm conscious of time, to our next speaker. And our next speaker is Elizabeth Bagginson. So Elizabeth, if I can ask you to switch on your camera. Elizabeth is a technical officer for the Migration and Health Programme in the Country Support for Impact Unit at the WHO Regional Office for Europe in Copenhagen. She's also a medical doctor, has a master's in disaster management from the School of Global Health at the University of Copenhagen. And Elizabeth has been working during the COVID-19 pandemic as focal point in the incidents management support team coordinating migration and COVID-19 publications for the region, and various other work around measures and recommendations to ensure these are inclusive of refugees and migrants. So we look forward to hearing your reflections, Elizabeth, also on some of our recommendations. Thank you. Go ahead.
Thank you so much, Nina, and good morning and good afternoon for those who is in that time zone. Thank you so much for inviting me to speak today. As Nina just mentioned, my name is Elizabeth Bagginson, and I work with the Migration and Health Programme here in Copenhagen at the WHO Regional Office for Europe. Some of you may already know that the European region is the largest of the WHO's regions and has 53 member states, stretching from Iceland in the west to the Russian Federation in the east, and including former Soviet states and as far south as Turkey and Israel, just to give an overview of that. I want to congratulate the European Network on Statelessness for compiling this comprehensive report and for drawing attention to a population group that is often overlooked. Our work at the WHO within refugee and migrant health deals mainly with international migration across borders, and stateless persons may of course be a part of this group. Our experience and research has shown that the health of refugees and migrants in general is good when they start their journey, but declines over time, both during long and arduous journeys, but also after arrival in host countries, due in particular to living and working conditions. And most of our work is centered around the social determinants of health, including the understanding that migration itself is a determinant of health. Today, with the limited time that I have left, I'll briefly touch upon a few of the recommendations that have come out of this report and relate them to how we have advocated and work at both policy level and through technical assistance to member states, not only during the COVID-19 pandemic, but also in our daily programmatic work too. This approach that I've taken today is because the idea of inclusion of all people and the right to health is, of course, the foundation of our work. So I'll move on to the technical aspects instead. But I fully understand and agree there's always more that can and must be done. And events such as this one and many other avenues and networks must be used at all levels of society so that we can move this agenda forward. There's no time to waste, as the report clearly shows. The first recommendation that I want to touch upon is the right to health. This falls directly under the constitutional mandate of the WHO that advocates for the right to the highest attainable standard of health and well-being for all. And we've worked on health policy and advocacy for several years to bring refugee and migrant health to the forefront of national and regional conversations. Migration is an age-old phenomenon and it won't go away in the future. Rather, it's increasing as the world becomes more globalized. Taking steps at country, regional, and global level to include all people, regardless of legal status, into national health systems at the earliest possible stage, is not only a matter of human rights, of course, but it's also a solid investment in the economy of a country and the health of the whole population through the strengthening of health systems too. The WHO Strategy and Action Plan for the WHO European region that was unanimously adopted by all 53 member states is the foundational document for our work within refugee and migrant health, and also the WHO Constitution, of course, the Global Compact on Migration and the Global Compact on Refugees, and currently also the GPW 13, which is the Global Program of Work at the WHO, and the EPW, which is the European equivalent. This includes the focus towards universal health coverage and primary healthcare, and recognizing also that the report that we are talking about today has found regarding healthcare costs and insurance schemes being a particular barrier that must be addressed through a multitude of actions at regional and national levels in both policy development and legislation, of course. At the country level, we engage in policy dialogues. We've hosted annual summer schools with a high level of participation to discuss and train leaders on refugee and migrant health issues, including health system strengthening, etc. And we also have a plethora of publications that can be accessed on our homepage, both dealing with policy considerations and technical guidance for implementers and healthcare providers. The second issue that I want to touch upon specifically is the access to COVID-19 testing, treatment, and vaccines. So access to healthcare during a pandemic is vital to ensure not only the health of those most in need, but also to protect the public health, of course. And specific steps that we've taken at the WHO include advocacy work with member states, as well as guidance, products, and recommendations that have come out continuously throughout the pandemic. In fact, the Migration and Health Program has been included in the IMST, which is the Incident Management Support Team at the WHO, coordinating the response from the very beginning, as the vulnerabilities of refugees and migrants and other vulnerable populations was very important to address from the beginning. This means that recognizing specific vulnerabilities such as legal entitlements and access to healthcare and the challenges and opportunities for inclusion of all members of society in response to the pandemic, both as responders, but also those requiring health and protection because of their demographic and health profiles. Specific technical assistance, such as country work with the establishment of testing and treatment sites, information campaigns about IPC measures and how to protect yourself even under challenging conditions, such as crowded living and working conditions, have also been distributed. Although we've seen a detrimental lack of access across the region, we do also see good examples, such as Portugal, that have included all migrants in the country to have access to healthcare regardless of legal status. In Ireland, there's also been extended more generous and inclusive policies during the pandemic. We hope, of course, that we can build on these initiatives in the future and to maintain these policies as we move forward. But let me be clear, there are very real and very serious gaps that we still must address across the region. I know I'm running out of time, and I have plenty more to say, including addressing discrimination and racism, and of course also to do with the data on refugees and migrants and stateless persons. I'm happy to continue talking. I'm also happy to take it up in the questions as we move on. But just to say that we have a lot of information on our homepage, and I can talk about this for hours and hours. So thank you for having us here today, and I look forward to what the discussion can bring.
Thank you, Elizabeth. Thank you, and I know you have a lot more that you could share with us. And unfortunately, we're tight for time, and I want to make sure that our audience can hear from our final speaker. But if our audience will bear with us, we are going to extend the time a little bit, just to another 10-15 minutes, so that we have time to hear from our final speaker, and hopefully to address some of those other points that speakers might like to raise in some final reflections. So please do bear with us and stay with us. But I'm going to move on to our final speaker, last but definitely not least, Mr. Henry Asher. So Henry is Professor of Public Health at the School of Public Health and Community Medicine at the University of Gothenburg in Sweden. And as both a practitioner and an academic, Henry's work focuses on social differences in health and ill health and how to reduce these. He has a particular interest in migration and health, with a special focus on children and families. So please, Henry, over to you.
Thank you very much. And I would like to start with thanking you for this fantastic report, which is so much needed, and I think really managed to grasp this area, which is very difficult to grasp, especially now during the pandemic. It's difficult to really get a grip of what is going on. I would like, I think also the pandemic emphasized the importance of the universal health coverage and the right to health, because the virus does not discriminate. It's human who do. And we need to fight the virus. I have been asked to give some examples of good practices, and I will try to get time for 3 short descriptions of good practices. First, I would like to talk about access to healthcare for undocumented migrants in Sweden. And it all started with the first UN Special Rapporteur on the Right to Health, Professor Paul Hunt, who visited Sweden in 2006, invited by the Swedish government. In his report, he was extremely critical to the government for the discrimination of the healthcare for asylum seekers and undocumented migrants. And this report, together with the work of the Right to Health Initiative, which was a kind of lobby group initiated by voluntary clinics for undocumented migrants in Sweden, and which gathered some 80 organizations from all civil Sweden, from the Archbishop, the churches, the big humanitarian organizations, the big trade unions, and all professional organizations in the medical and healthcare area. And out from this pressure, and after a lot of political ado, there was a law implemented in 2013, which gave the right to health care for people who were staying in Sweden without permission. It included subsidized acute care and care that could not be deferred. This term, care that could not be deferred, is, however, causing a lot of confusion in practice. And the law says that the responsibility to decide whether it is care that could not be deferred is, the responsibility is put on the individual doctor, dentist, or nurse. Because of this, it creates a lot of uncertainty among health professionals. So in practice, there are a lot of problems. But still, it gives a right for people who are not allowed to stay in Sweden to have the right to health, in some ways at least. The second example I would like to tell you about is the involvement of the target group in work with COVID information. And I will give an example from Angered, which is a suburb to Gothenburg with about 100,000 inhabitants, the vast majority with foreign background. The local hospital there, Angered Hospital, has had a long collaboration with cultural interpreters, which is inhabitants with the big social networks living in the area and who had received health education. When the pandemic arrived, they were involved in spreading information and adapting information. And they have used not just innovative methods for spreading information, but also adapted the content to a format and using channels to spread informations adapted to how to reach out in a good way. An evaluation has been done, and this emphasized that dialogue is central, not just one-way information, but a dialogue where people can ask their question, raise their doubts, and so to have a discussion. And this is a fruitful way to spread information. The third example is the planning of the vaccination strategies in the western region of Sweden, Västra Götaland region, with about 1 million inhabitants. The region who is responsible for the healthcare, they have made a very good work by gathering people with knowledge in order to reach or develop strategies to vaccinate the so-called difficult to reach groups, which means undocumented asylum seekers, foreign-born, homeless people, EU citizens, mainly Roma citizens in Sweden. They have gathered knowledge from people on the ground, both from local authorities and community organizations. And they have gathered them for several meetings and taken up their thoughts and made a very good plan for based on reach out and flexible strategies. Also they have recognized the need to keep firewalls and of course, and also no need for ID cards. And I can also add to that testing and vaccination in Sweden is free. So I think I will stop there due to the lack of time.
Thank you so much, Henry. That was really useful and really interesting to hear some ideas and food for thought that can be perhaps rolled out in other contexts to address some of the challenges that we've been talking about. And it's fantastic to see that we still have over 90 people listening and bearing with us despite having gone over time. So that just shows how much interest there is in these issues. So we have a few minutes, hopefully, in which we can ask all of our speakers to come back, hoping that they still have 5 minutes or so of time available to respond to any final or make any final reflections. So I'd just like to, I think, invite perhaps a 1 minute final reflection or thought from each of you on what we've heard today and anything else that you weren't able to raise in your presentation. So I'll just kind of go through each of you and call on each of you in turn to give your final reflection before we close. We have had one question from participants, so a question from Celian, who asks, how can we really address this situation at state level when states are not implementing their international obligations? So he gives the example of Ireland, which is party to the 1954 Convention, and in his view isn't implementing the convention fully, but certainly from our experience, that's not the only country where there are challenges and issues with the implementation of the 1954 Convention relating to stateless persons. So if anybody would like to address that question, perhaps Fernand or others, about other ways to address these issues beyond state level. But I'll go through each of our speakers in turn and let you give us your final reflection. So let's start with Elvis, if we may. Elvis, would you like to start?
I will use this very little time to share with you now in period just while I was presenting my presentation. We received a letter, a response from the health insurance fund, in which we were told that a Roma woman who is very ill and needs gynecological surgical interventions cannot have free health treatment because there is no legal basis for this, even though they are aware of her difficult health and material situations. Since she is pregnant and in the fifth month of pregnancy, all we have to do now is to pray to God to save her and her baby, who is not sure that everything is fine. So I thought that it's important to share again this with you, because this is concrete cases that show us that really the people who have not regulated their legal status in Montenegro are not just people who have a problem with documentation. They have problem with healthcare and all other problems. So regarding the question, I think I'm not I cannot answer maybe concretely. So I will maybe someone of other panelists can answer. So, and also for the end, I really want to thank again to ENS and the other partners for inviting me and opportunity to share these issues and problems which we are faced in everyday basis. Thank you.
Thank you very much, Elvis, and really sorry to hear about that case, but thank you for sharing it with us. It's really important, as you say, that these cases are heard. So Fernand, would you like to go next? I'll come to each of you in the turn that you spoke and finish with Marie-Claire. So Fernand, go ahead.
Thank you very much. I think in the case of the convention, the question concerning the Convention on Statelessness, one has to acknowledge, first of all, that treaty would not resolve every problem. It is a rather old treaty, and it does have a number of restrictions. So I don't think, if I may express my view here, I don't think we should assume that this treaty would solve every problem in any event. What I would urge you to consider is that that's not the end of the story. There are other human rights that can be applied to issue of citizenships and denial or stripping of citizenship, such as the prohibition of discrimination. It's not well understood, but actually the prohibition of discrimination in international law under Article 26 of the Covenant on Civil and Political Rights also applies to citizenship denial or determination. And that would indeed address many of the issues around statelessness, in my opinion, if it were properly applied and understood. One last comment. I think what you've done with your assessment, which is should be emphasized, is that you're focused on the most vulnerable and marginalized, the stateless people. And by the way, as part of my mandate, it has been clarified that most stateless people are minorities. And this also is not always sufficiently acknowledged. More than 3/4 of the world's stateless people are actually from minority backgrounds. And it is there that we need to focus on those who actually might be more vulnerable, unable to access medical services, unable to access, in some cases, vaccination without a number of barriers. And so that means to be effective, we need to focus or to address the pandemic measures on those that are most vulnerable, including perhaps mainly stateless and other minorities, including migrants and refugees.
Thank you very much, Fernand. Thank you. Dragoslav, go ahead.
Thank you very much. I'm saying in general that every crisis, every challenge also provides for some opportunities. So also I'm trying to keep this motto during the pandemic and during the situation which is very much worrying for migrant population and asylum seekers. But I'm happy that I've heard and I've seen some good examples as they have been mentioned. The countries like Portugal, for instance, or today, Mary Claire, I think, mentioned the program Patients, Not Passports, which is very good initiative, very nice one, and has very nice message also about it. As Professor Göteborg said, the virus does not discriminate, so we should be also quite pragmatic, and that can also provide results, tackle any discrimination vis-a-vis stateless persons. So for me, also kind of stateless persons are undocumented migrants, because I would call them, they are kind of de facto stateless because they can't establish a formal link to state with the lack of documentation. So I'm also very much looking at that category. Thank you very much again for this seminar, because as I said, this category is quite invisible. It's quite often neglected, and it's good that we hear about the people who have no state nationality. And concerning the implementation, of course, there are a number of national human rights institutions, ombudspersons in the countries. If a treaty does not have a monitoring mechanism itself, but I think 1954 Convention does not have any monitoring body or monitoring organ which will monitor the implementation of that particular convention. So that will be my advice for a person who was seeking advice concerning the non-implementation of the 1954 Convention. I thank you once again.
Thank you very much, Stanislav. Thank you. Elizabeth, over to you.
Thank you so much. Yes, and just to pick up on that and the implementation at country level. So by now we have a fairly good and broad baseline knowledge of the health status of refugees and migrants, and within that, of course, also irregular migrants and stateless persons. But the move that has recently been done in restructuring the regional office, where we now belong to the Country Implementation Support for Impact Unit, it's a very long name, but it reflects the idea that we now must move towards a much more focused approach at country level, so that we can reach those most at need, because we have the knowledge, we have the evidence. Now it's time to act and engage with countries directly, so that we can see a real movement towards universal health coverage and to fulfill the right to health for all, because it is such a multifaceted and a compounding of vulnerabilities when we talk about, as was also mentioned by previous speakers, of these many faceted influences that come in from being either stateless or an irregular migrant, perhaps belonging to an ethnic minority, having a growing burden of non-communicable diseases, and then during a pandemic lacking access to healthcare. So there's a multitude of things that we have to address. But it starts at country level, and it starts with us also taking on the responsibility from our side as well, which I think we certainly try to do, but an increased focus is never a bad idea. And then to recognize that we also have more work to do at our level as well. So thank you.
Thank you very much, Elizabeth. Over to you, Henry.
Yes, I think the pandemia that we now experience really underlines an eternal truth, namely that discrimination not just affects the targeted individual, but the whole society and all of us. It is so clear. And I think also it is so important that we stick to human rights and the medical professional ethics. The modern forms of human rights and the medical ethics has evolved out of the experience of a period in human history when we when we disregarded all of this, the horrible experiences from that period of time. And in order to prevent such horrible events to develop again, it's very important that we keep strict to those experiences and work along the lines of human rights and medical ethics.
Thank you very much, Henry. Thank you. And last but not least, Mary Claire, a final reflection from you. Go ahead.
Thanks, Nina. Thank you, all of you, for your wonderful reflections, many of which all of which I would like to echo. I'm struck by the discussions and the research that we did that there continues to be such a divide between the state obligation regarding right to healthcare and the non-discrimination provisions. We need to move this beyond a right to emergency healthcare, and the definition of that is so important now within the COVID-19 public health emergency. That's my first point. My second and final point is that even though we all recognize their rights, the practicalities of ensuring public health support for stateless people and the groups they belong to is so crucial. It needs to be done in a very sensitive way. You know, we cannot exclude anyone. Fernand has already said this, and many others. In this, we need to all work together in order to be protected from this disease. And there are still practical issues regarding vaccination campaigns, which are hampered by this institutional mistrust around who's vaccinating me, what are they injecting me with? And from the healthcare provider side of things, how do we record who's been vaccinated? How do we follow them up for their second and their third doses? Where are they? How do we find them again? You know, there are logistic and practical issues that need to be tabled, going beyond, you know, the higher level thought of, yes, we need to assure their human rights. So that's my final point on this. Thank you.
Thank you so much, Marie-Claire, and thank you really so much to all of our panelists today for taking the time out of what I know are really extremely busy schedules at this time to share your insights and your expertise. You've really given us a lot of food for thought and reflection to take away. And thank you to the 85 participants who stuck with us to the end, and to the more than 100 who joined us for the webinar today from all corners of the globe and participated through the chat. It really is great to see that interest and commitment to this issue. So we encourage you all to read the report, share it, share the policy briefing around your networks, and think about how we can ensure that stateless people are more visible and importantly participate in the response to the global pandemic and are able to realize their right to health. So as I said before, if we don't take this action now to identify who and why we're leaving people behind, we will have learned nothing from the pandemic. So with that, and without any further ado, I would like to wish you a great rest of the day or evening, depending on where you are. Stay safe. Thank you again, and goodbye, everyone.